Unexplained fatigue is one of the most frequent presentations in primary care, yet it remains one of the most difficult to resolve. This patient's lab work is often screened using a traditional serum ferritin cutoff of 15 micrograms per liter, a threshold many general practitioners still rely on. Statistically, that cutoff catches only 59% of true iron deficiency cases. This leaves 41% of iron-deficient patients undiagnosed and untreated. A normal hemoglobin level on a complete blood count often creates a false sense of security, masking the underlying pathology. We are updating the diagnostic roadmap for iron deficiency anemia using current evidence from the American Gastroenterological Association and the British Society of Gastroenterology. This update requires 3 shifts in clinical thinking: upgrading diagnostic thresholds, deploying gastrointestinal stewardship, and resolving the hepcidin treatment bottleneck. When we rely on outdated lab thresholds, an objective diagnostic test becomes a clinical blind spot for millions of symptomatic patients. The American Gastroenterological Association provides specific recommendations for diagnosing iron deficiency in patients with anemia. They recommend moving the diagnostic cutoff for ferritin to 45 micrograms per liter. This adjustment provides a statistical leap in detection. Shifting the threshold to 45 increases sensitivity from 59. Because hemoglobin is a lagging indicator of iron depletion, ferritin is the metric required for early intervention. Interpreting ferritin is complicated by the fact that it is an acute phase reactant. Systemic inflammation can artificially inflate ferritin levels, masking an underlying deficiency. This is particularly common in patients with chronic inflammatory conditions or chronic kidney disease. When ferritin returns normal or high in these patients, a specific diagnostic pathway is required to confirm iron deficiency. Verify the clinical picture with secondary biomarkers, C-reactive protein and transferrin saturation, or TSAT. A TSAT under 20% confirms iron restriction, regardless of the ferritin reading. TSAT identifies the restriction at a cellular level, cutting through the noise of inflammatory proteins. In the presence of inflammation, relying on ferritin alone is a clinical trap. Secondary biomarkers are necessary to avoid missing a diagnosis. Unexplained iron deficiency anemia is linked to a 10% risk of underlying gastrointestinal malignancy. The British Society of Gastroenterology provides a management algorithm to address this risk. Bidirectional endoscopy is the standard diagnostic approach to evaluate both the upper and lower tract. This investigation is the recommended first-line approach for men and postmenopausal women. All patients with iron deficiency anemia must also be screened for celiac disease using either serology or a duodenal biopsy. Clinicians should also perform a urinalysis to check for microscopic hematuria, ruling out renal tract pathology. However, the approach changes for premenopausal women with non-anemic iron deficiency. For this group, the statistical risk of gastrointestinal malignancy is very low. In this demographic, the primary causes are almost always routine menstrual loss or recent pregnancy. If iron deficiency anemia recurs even after a negative endoscopy, further investigation of the small bowel is necessary. Capsule endoscopy is the preferred tool for locating subtle vascular or inflammatory lesions that other scans might miss. Effective investigation requires an urgent hunt for malignancies in high-risk patients, paired with clinical restraint in low-risk groups. Regarding treatment, we need to move away from the habit of prescribing oral iron 3 times a day. Iron absorption is regulated by the hormone hepcidin. Hepcidin levels spike immediately after a single oral dose of iron is taken. This spike triggers a wave of blockade molecules that shut down the cellular exit gates in the gut. This creates a 24-hour blockade that prevents further iron absorption. Multiple daily doses fail because they are taken while this blockade is active. The extra iron is trapped in the gut, causing toxicity without any therapeutic benefit. The updated treatment algorithm aligns dosing with these biological realities. The standard recommendation is now 50 to 100 milligrams of elemental iron taken strictly once daily. Alternate day dosing is often even more effective, as it allows hepcidin levels to subside between doses. Success is measured by a hemoglobin rise of at least 10 grams per liter within 2 to 4 weeks. If the patient does not meet this target or cannot tolerate the iron, the protocol requires a transition to intravenous iron. Respecting the body's natural hepcidin rhythm is the scientifically valid method for achieving clinical results. To apply these updates, keep 5 takeaways in mind. 1. Use strict WHO criteria for anemia, hemoglobin under 130 for men, 120 for women. 2. Upgrade your diagnostic thresholds to the 45 microgram per liter ferritin cutoff to catch more cases. 3. Look for non-anemic iron deficiency in symptomatic patients before their hemoglobin levels drop. 4. Use TSAT and CRP to verify iron restriction in patients with chronic disease or inflammation. 5. Stop prescribing iron 3 times a day. Use once daily or alternate day dosing, and escalate to IV iron when needed. When you review your patient panel tomorrow, consider who might be missed. Effective management requires looking past a reassuring hemoglobin count to find the pathology hiding behind a ferritin of 30.